Thank you, Deborah. That was very nice. We have a limited amount of time, maybe for a couple of questions. So I'll have our chair go ahead or incoming chair start.
Thank you very much for your wonderful work, innovative, high impact. I have the privilege to sit on the board for one of the largest social services organizations in the Midwest, known as the Chinese American Service League, that serves over 32,000 Chinese clients on an annual basis. And if one of my community partner were here right now talking about the linkages between what we talk about with culture, mental health services, resources, stigma, and they may paint a very different story in the sense that, the word depression is a synonymous with the word term schizophrenia in our community. As a geriatrician myself, in our community, I cannot find a single geriatric psychologist or psychiatrist in the greater Chicago area to refer my patients to. Even if you had resources in our community, I would not be able to provide the care that I think they need in the community setting. As a substitute, many of those patients are ending up getting community services as a substitute, as a proxy, using perhaps a non-mental health professional caring for their needs. So that's one comment. And my question to you is, I've heard the word support quite a bit over the last couple of days. Social support is a tricky thing when you look at epidemiological research, in the sense that, too little social support is a bad thing, but it could also be too much social support could be a bad thing. I used the analogy, how do you know Lipitor works for you for cholesterol? How do you know 5 milligrams of Lipitor will lower your cholesterol? And how do you know 80 milligram Lipitor wouldn't give you fulminant hepatic failure? When I think about mental health services and intersection with violence and mental health interventions, I think about that dial. I think about, how do we know what is the gradient relationship between support services that we aim to provide in terms of endpoint reducing mental health disparity and violence, and where is that gradient? So I would like to get your thoughts on, through your experiences, where's the dial? Where's the, how do you measure that? How do you evaluate it? Thank you.
Thank you for your comments. I think just to begin with, one important concept is the any open door concept, and that we need to create a service delivery system that is receptive to the desires of individuals in their experience, and that may be building a more robust primary care system that has the capacity to deal with a variety of different needs beyond physical health needs, to be able to better integrate. I think that within lots of different communities, for people where we've identified a serious mental illness, we do a very poor job getting their general health care needs met, and vice versa. People that come into primary care aren't being diagnosed and treated in appropriate ways. And so this can extend to the kinds of peer support models that we were hearing about later, and fundamentally doing a better job trying to provide care in ways that are meaningful to individuals based on where they come from and who they are. And I think even in Chicago, there are actually some very good models that are trying to move us and move the needle a little bit with regard to doing this. But I think that right now there are such serious problems with undertreatment, not getting people into treatment, and that potential connection to violence, although not always obvious connection to violence, speaks to the need to find ways to make services appealing and valued by the individuals that would use them.
I again thank the panel, and I'm struck by the heterogeneity of services, not only within this country, but within this continent, this hemisphere, and the world. And I thought, Devendra, your statement, from what you say to what you do, there's a long way to go, Do you think we're doing it well? Okay, you got it. I think in this country, our biggest provider, we have a solution. We have some very big providers of mental health services, and they're called jails. So the part of the Affordable Care Act that provides coverage for people in jails is, in essence, providing coverage for people in our largest psychiatric institutions. That's absolutely important. But it also strikes you that this system is not one that we want to copy and disseminate throughout the rest of the world. So it's like no one has it right. No one has it right. And boy, there is a long way to go, a very, very long way to go. And in terms of equity and inequity and parity, these are really striking, both in terms of country to country, but also in terms of physical health and mental health. There is such a long way to go, and this is such an important area for improvement. And thank you for helping clarify all of that.
Following up on what Mark said, I have two comments. One is that China just passed a major mental health law earlier this year, and it has transformed all the involuntary admission to voluntary admission, except for a very small proportion. And one thing that's a great human rights advance and stuff, but it's clear what's going to happen is that these people are going to end up in prison now. And you know, the downsides of moving for human rights, if you don't have a service delivery system in the community, it often will result in the jails. And the other issue that I think is important is that there's no way, you know, my research shows there's 173 million people with current active psychiatric disorders in China, 173 million. You know, there's 20,000 psychiatrists, almost no psychiatric nurses, and no social workers or anybody else. There's no way that the mental health professionals are going to provide any service. General physicians and nurses get no training in mental health during regular medical schools. They don't treat it, don't want to treat it. So where are we going to find the providers for these services? Nurses hate psychiatry. They don't want to do it. They'll do anything other than work in psychiatry unless they can get to a big city to work in a psychiatric hospital. So I think the other side, one of the other sides we've got to focus on is how do you encourage community health workers, or how do you motivate people to provide these services? And with the huge burden of dementia that's happening in China with the rapid aging of the population, who's going to provide service for those people? Has no idea. And we can say, well, you got to get people willing to use services. That's one side. But you've got to get people willing to provide services. And seeing this as an honored profession, a profession that has self-esteem and status. As I said yesterday, what's happening in general hospitals now, patients and family members are attacking physicians and nurses. Every day it's in the press. And they have to put police in the jail, in the hospitals, just to protect the staff from being attacked by patients. Who wants to be a psychiatric nurse or doctor in that situation? And so we've got to think of how do you make this profession a little more attractive for young, bright people to take over these positions. If you don't, we're not going to get anything done.
We can take a couple more questions and then we're over time. Madeline.
Thank you for your comments, and I learned a lot. I want to just follow up on Colleen's work. There is an experiment going on under the ACA in Connecticut of creating healthcare communities, with the quarterback being a psychiatrist or an advanced practice nurse in psychiatric nursing, with the idea that you bring psychiatry to to the primary care, and you let that person sort of organize the overall health care, since many people with chronic illness also have mental health issues, although they're not diagnosable. So I thought that was interesting to hear. And the other about school health. When you talk about stigma, in schools still today, there are the good ways to have behavioral problems and the bad ways. And so what's very interesting is the number of children who are incarcerated in this country, and the number of children shifted from school to the criminal justice system. Since the juvenile justice system was criminalized, within the last 20 years. And that group tends not to get mental health.
I think maybe a follow-on to that is just the number of children that are kicked out of school, suspended or
That's right.
such, and as a consequence are out of the health system. You in front in the blue shirt.
Thank you. So I appreciate the comment that was just made about human rights. I'm sorry, get my share in there. But, you know, I was at a testimony, a hearing about the use of coercion and should it be expanded. And I saw a well-respected Latino psychiatrist believe that the only way to get his community the care it needed was to use coercion. And I just think that's a bad reflection on our system if we feel like we have to make up for our inability to engage people and use our best sort of technology and replace that with coercion. So if somebody's a danger to self or others, they can be involuntarily hospitalized. But on the outpatient basis, I think I don't think that taking away people's human rights is a good substitute for good, responsible engagement.
Thank you. And I think with that, we're over time enough that we're going to
Hi. Yeah, I thought I was called on. That's why I came over here, but then I couldn't tell. Can you hear with this?
I guess
I'm-
one person, go ahead.
Yeah, I'm Dr. Betty Lee Davis, and I'm a clinical practitioner and not a researcher, but in recent years, I've become very interested in youth violence, and in particular, youth violence as a public health epidemic. And I have a question in the event anyone here can answer. And then I want to make you aware of a legislative initiative in Pennsylvania that's gone national. The question is, if there's anyone here who could answer what happened in the year 2000 to the Surgeon General's report declaring youth violence a public health epidemic, because as far as I'm aware, it was never treated as a public health epidemic. So if there's anyone who can shed light on that, it would be of great interest to me. In the state of Pennsylvania, there is currently a legislative initiative in process declaring youth violence a public health epidemic and calling for statewide trauma-informed education. And it's House Resolution 191. It's gone to the national level. It was adopted with a full bipartisan vote in the House of Representatives in Pennsylvania, 187 to 9, which was pretty remarkable. Representative Ron Waters took it to the National Conference of Legislators, where it went through the Health Committee there. Unanimously, it was adopted by the body, so everyone here can contact your own legislator in regard to this. It's House Resolution 191. It was also taken to, by Representative Waters to the Legislative Black Caucus, the national gathering, where it was also adopted unanimously. So there is a movement afoot. It's open to all states now. It's something that legislators will be taking back to the states to open the conversation. Anyone who's interested, I have a limited number of copies of the resolution I'd be glad to hand out. And anyone who could answer my question, I would be interested in the response.
Maybe what we could do is if you could talk to Jim Mercy, who's had a role in putting together the Surgeon General's report and has been very involved in the response during the break. That might be a good connection. Thanks for letting us know about that.
Thank you. And anyone who would be interested in this, there are about 8 copies.
Mark, can I say one thing, just one thing? I'm Julia Silva with the American Psychological Association. I'm involved with the Department of Justice. They have the National Forum on Youth Violence, and they are funding 10 or more cities in the country. It's a wonderful experience that they are doing in a number of cities with putting together a lot of stakeholders, a lot of community partners, Chicago, Detroit, Boston, California, Miami. So there are many things happening here too. So I don't want people to go with, something very negative. There are a lot of experience happening in this country and everywhere. So thank you, sorry.
I would also say that previous work of this forum has focused more on youth violence, and take a look at some of the previous workshops that bear on that topic. Let me thank the panel again and AJ, and it's now 11:30. We will take a 10-minute break and we'll come back at 11:40. Thanks, everyone.